Okay, here we go. Let me see if we got people here though. Not really. Okay, well, I'm going to lecture anyway. Okay, so for those of you, I'm not doing Zoom right now because this is easier for me to get content done, and then we can Zoom question and answer type stuff later, or we can Zoom worksheets, or we can Zoom other stuff, okay? It was good to see you the other day, but we're going to keep doing this way. So, if you have a question, make sure you put it over in the chat area there so that I can see it. Um, if you haven't turned in your corrections for your quiz, or you haven't done quiz 2 review, then I need those in. So make sure they get them over this way, okay? Okay, so we have made it through the structures of the heart, right? We've made it through just the general anatomy that goes along with it. We've made through the chambers of the heart. We've talked about the valves and the pectinate muscles. We've talked papillary muscles and the mitral and the bicuspid and the chorda tendineae. We've talked about the different chambers. We talked about the receiving chambers and the discharging chambers. And then we got into heart sounds, and we've talked about the pulmonary circuit and the systemic circuit, and we kind of understand how the heart gets fed oxygen and blood, and we talked about the flow. We even talked about the electrical events that are happening. And so really what we've kind of done is we've taken a good view, an overview of the heart, and how it looks, and how it was made. There was not any trick questions on the quiz, and also some basic information on how the electrical portion of the heart works and how that has to coordinate. Okay, and as we go back and look at from chapter 1 all the way through where we're at now, all of these systems that we have learned coordinate with one another. With we talked about the blood, and we talked about skin, and we've talked about the heart, and all the nervous system, and all these things coordinate with one another. And hopefully, as we go, we can see how that pieces its way together, and we can see all that. All right. So we talked about this conduction system, on how it starts here and travels across the atria to the AV node, down the bundle branches through the. All right. We talked about that. We talked about contraction and relaxation, and we talked about how we, during these different stages of contracting, relaxing, how blood is moving, whether it's moving passively while everything is relaxed, or if it's moving actively. And there's some cases here with knots, they're in the ventricles, where the ventricles start to contract and blood is, excuse me, blood is pressurized. However, it's not moving yet because the pressure is not strong enough for it to get through the semilunar valves, right? And then we talked about the ejection phase. All right, so we've got a pretty good idea on the basics of how the heart works. We've got a pretty good idea of what structures should be there and how they should operate. We have a good idea of the electrical portion of the heart and how it should work. Sorry, I'm chewing a piece of gum. Alright, so since we know all this now, since we understand what's going on, we can take what we know and apply it based on when we talk about disorders. Okay? Now, obviously, we don't have a textbook. Okay? And so, you can simply do things like this. With this page right here, what I would suggest that you do is just do like this. I mean, basically, we're gonna say heart block. Okay. And so what a heart block is an abnormal heart rhythm, okay, where the heart beats too slowly. Okay, bradycardia. So that answers two of your questions there. So a heart block is where some of the signal is getting blocked. Okay, bradycardia is a heart rate that is slow, slower than normal. Tachycardia is a heart rate that is faster than normal. All right, so when we talk about a heart block, and electrical signals that tell the heart to contract are partially or totally blocked between the upper chambers and the lower chambers. All right, so since we are smart and we know what this kind of looks like, a heart block is where we're going to have some type of an issue conducting the signal from top down, right? So either something's going on here, something's going on here, something, okay? But regardless, we have a blocking of the signal, so it does not allow it to travel, hold, travel, contract, right? All right, so you could do the same thing with bradycardia, right? Bradycardia, heart rate that's too slow, okay? Elderly, a resting heart rate of fewer than 60 beats per minute qualifies as bradycardia, okay? Um, Tachycardia, make more than 100 beats per minute. All right, so what they're going to say is normal is between 60 and 100 beats per minute. Okay? There. All right, so you can kind of go through all this type of stuff. But when we talk about that first slide, some of these things that I think you should do is a heart block is a blocking of the signal. That's going to do a couple different things. It's either going to make a heart rate that goes crazy fast, over 100 beats, or slower, under 60 beats. Sorry. Okay. 4 people here. Good. Okay. So the next group here is where we're going to talk about congestive heart failure. Okay. Congestive heart failure. If we go here, right? It's a chronic thing, right? So if it's chronic, that usually means it's going to affect the elderly, right? It takes a while to be chronic. Okay. It affects the pumping power of your heart muscles. All right. People, they will refer to it as heart failure, but fluid can build up around the heart and cause it to pump inefficiently. Okay, so fluid can build up around the heart between the parietal and visceral pericardial linings, and then that pump, since we have a bunch of fluid on the outside, that is not going to be able to pump well. And so if it doesn't pump well, that means it doesn't move blood well, right? So if we think about this, right? So we have, if we go back up to here, um, and we go to here, right? We have our heart. Our heart's a pump. It pumps two different things, right? Well, not one thing, but we have a pulmonary circuit. So the right side of the heart pumps to the lungs, and then we have the left side of the heart which pumps to the system, to the body, right? So if our pump becomes inefficient and we're not able to pump as well or pump as much, then that means things tend to back up, right? And they tend to sit around and they tend to pool and puddle, or however you want to think of it. And so when we have congestive heart failure and when the pump isn't pumping well, we can get pulmonary congestion, meaning if, or peripheral congestion, right? If the left side of the heart is not pumping well, we can get, so then that's not going to pull blood out of the lungs as well. Blood's going to kind of stay in the lungs as well. Then we tend to have maybe some plasma that slips through those things and fills the lungs full of fluid. If the right side of the heart isn't pumping well, we're not going to get blood pushed to the lungs very well, but then as a result, then we're going to get a backup of returning blood in the body. We're going to get some peripheral congestion. Okay, so when people have congestive heart failure and they die from congestive heart failure, a lot of times what ends up happening is they drown. They're drowning in their own fluid. Their lungs fill up with fluid, and it takes away the ability for them to exchange air, and therefore they basically drown. And so people with congestive heart failures, many times they will be on Lasix, and Lasix it's a diuretic, and that causes people to urinate more, pee more, and then that gets the fluid off, and that helps them combat the sluggishness of the heart. Okay, pretty common thing right here. All right. So here's some other disorders that we're going to talk about. Okay. So an ectopic focus, it is a defective pacemaker, and it results in the AV node becoming the new pacemaker, and interferes with pacing of the ventricular depolarization. Okay, so let's just read it one more time, and I'll go up to the diagram. Right. So a defective pacemaker, right? And which node does that? Typically, it is it's the SA node up here, right? So we have a defective pacemaker. So the SA node is no longer the normal pacemaker, and this AV node becomes the new pacemaker. All right, but the problem with that is the AV node is designed to do what? The AV node is designed to delay. Remember? Delay and then send the signal. All right? So now, if all of a sudden this thing is sending the signal and not the SA node, that's going to mess with the pacing of the ventricular depolarization, right? So if this thing sets it, then you're going to start to get a signal start here, which is going to depolarize the atria and the ventricles at the same time. Okay? Problem. That's a problem. All right? Extrasystole. So if we think about this, so extra is extra. Systole is what? Contraction, right? So we have an extra contraction. So they call it a premature contraction. A section of the heart may become hyperexcitable due to caffeine, nicotine, whatever, and start generating a quicker impulse, interfering with normal pacing, right? So again, if the ventricle fires a little bit too quick, then that means that the AV valves are going to close sooner, which means the atria aren't going to dump their blood as quick, which means a lot of stuff. All right, and so this pacing, if you remember right, the contraction, the delay, the contraction, it is designed so that we can get fully emptying atria, fully emptying ventricles, and it can pace and time itself so that the blood moves efficiently through. Okay, well, these two things here, when you start messing with the nodes, you start causing a node to do something it's not designed to do, it's going to mess with that normal pattern. Same way with here, whether you're going to drink 15 monsters at once, we could probably do an experiment where we, I don't know, gave Chris 5 monsters and see if we couldn't get him to get an extra beat in there. Anyway, we wouldn't do that to Chris. Well, maybe we would. Anyway, all right, so more disorders. All right, so a decompensated heart, seriously weakened heart, it's irreparable. Okay, they just call that a decompensated heart. All right, so it's a very weak heart. It's not something that's going to be repairable. All right, now when we talk about congenital heart defects, these are things that are present at birth. Okay, anything congenital is present at birth. Okay. So we have a patent ductus arteriosus, right? The duct doesn't close properly at birth, allowing oxygenated and deoxygenated blood to mix. Okay, so if we look here, a normal heart looks like this, right? So we have our superior and our inferior vena cava dumping into the right atrium. We have our bicuspid valve, goes through there into the ventricle, through the pulmonic center to the right. Well, in the fetal system, right? We bypass the lungs. Okay, we get stuff. We're getting oxygenated blood from mama, and so we don't need to go to the lungs, and so we have this ductus arteriosus that goes from the aorta to the pulmonary trunk. Okay, when we are after we're born and we take our first breaths, then this thing tends to clear up. Okay, and it ends up being this ligamentum arteriosum, blah 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 blah, right? Well, if it would happen to stay open, and we are going about our day, and now we are air breathers, we're not getting our blood from mama anymore, we are air breathers, then that means we need to send things to the lungs, okay, which means we're going to go through here. However, now if you're going to start to take, and you still have this remnant and this tube that allows some of this oxygenated blood to pump into this deoxygenated blood, or deoxygenated blood to push up into the aorta, that's inefficient. That's a problem. We're either going to try to oxygenate oxygenated blood already because it's going to go to the lungs, or we're taking deoxygenated blood, putting it in with oxygenated blood, and sending it around the system again, which is not good. Okay? So patent basically means left open duct artery, right? So an artery duct that's left open. An artery duct that's left open. Normally it closes when we take our breath, okay, first breath. Or we can have a septal defect, right? An opening left in the septum, possibly due to the open foramen ovale or developmental defect, right? So we had that foramen ovale, that was that passageway between the atria, right? So we can skip the lungs. When we take our first breath, that tends to close immediately. Well, sometimes we can have this septal defect, right? We can have an issue where that is left open, and now we're spilling oxygenated and deoxygenated blood. Those happen pretty often. These things kind of can happen, and generally they go in there and they fix them, no problem. Okay. So there's those two disorders, okay? And then we go into this one right now. This one here, tetralogy of Fallot, is a big deal. Okay, this is like we're doing an ultrasound. While the baby, those ultrasounds, and everybody goes and they're trying to just find out the sex of the baby. Are we having a boy or a girl? This is where you can pick up some of this kind of stuff going on here. Okay, and this is a big deal, right? So if you look here, surgical repair as soon as possible. And you're going to find out why here as we look at this, all right? So let's go through these. So tetralogy, tetra is 4, all right? So 4 defects of the heart all at once, okay? We're not talking about some leftover artery that's mixing a little bit of oxygenated and deoxygenated blood. We're not talking about a hole between in the septum, because they can fix these things pretty easy. It's just you just kind of go in there and you fix them. Now, when you talk about tetralogy of Fallot, now we're talking about a whole other ball game. Okay, so a stenosed pulmonary valve. What stenosis means is that things are smaller than they should be. All right, so if the pulmonary valve is smaller than it should be, so let's say if it's supposed to be the size of a nickel, but yet now we're looking at it, it's about a quarter, and now it's the size of a dime. Okay, that's going to affect how much blood is going to be able to pass through that. All right, it's going to affect how hard the ventricle has to work, right, to pump up blood out of a smaller opening. Okay, so that's one issue. The pulmonary valve, the pulmonary semilunar valve, is smaller than it should be. Okay? Now, the other one is we have an aorta arising from both ventricles. All right, so the problem with that is what? The aorta is supposed to come off of which ventricle? The left ventricle, right? Good answer. So the aorta is supposed to come off the left ventricle, right? And that's fine. That's normal, right? Because the left side of the heart is the systemic side. That's oxygenated blood. That's shooting all over the body and whatever else, right? However, if we have an aorta that arises from both ventricles, that's a problem, right? Because now this ventricle is the right ventricle has two issues with it now. The right ventricle has this tiny little pulmonary valve, a small opening to go to the pulmonary trunk, but now also we have an aortic opening in the ventricle, which is going to push, when that ventricle squeezes, is going to push blood to both, into the aorta from both the right and the left ventricle. All right, so that's a problem. We have an interventricular septal opening, right? So we have the septum between the right and left ventricles is not complete. And so therefore, what are we going to get? We're going to get the spilling of blood back and forth, oxygenated and deoxygenated. We're talking about a completely inefficient system. And then we're also going to have a right enlarged ventricle. Why would we have that? Multiple different reasons. Well, here's one. We got to try and pump blood out of a smaller hole. Now we're pumping blood into the aorta, which means it's going to pump it to a bigger area, which is going to have to increase the pressure. Here, where it's inefficient, because now we're kind of pushing blood back and forth from the septum. It's not contained. All right, and so all of those things is going to cause the right side of the heart to work harder than it is supposed to, and therefore we're going to have an enlarged right ventricle. Right. So if we look at this, right? Oops. Tetralogy of flow. Superior vena cava, inferior vena cava, right atrium, bicuspid, down into the right ventricle. Now look, we got all kinds of messed upness here. Okay, we have that. Look how small that valve is. Look how big this is for the aorta. Small. So it's small. So that's going to make that right side of the heart work hard just to even try to get through that smaller opening. We can see that we have an aorta that is over the septal defect, and it's getting blood from both the right and the left ventricles. We see the ventricular septal defect right here, right? This should be complete. These should be separated, but now we have this thick right side of the heart because it's working way harder to pump blood this way, this way, this way, this way. And so we can see how this is a major heart surgery. They've got to go in and they've got to repair this. They've got to go in and they've got to reposition this so that it is over only the left ventricle. They're probably going to go in here and put in a different valve to make it bigger. And then once the heart gets working normally, what we would hope to see is this right ventricular wall kind of chill out. Okay, so the sooner that you can get this done in someone, the better. But again, that's no minor surgery there. Okay. Okay. Man, I'm gonna blast through this whole thing here soon. Okay. Okay. All right. So, other things that go wrong with the cardiovascular system, right? Arteriosclerosis or atherosclerosis is fatty deposits on the blood vessel walls. It's accelerated by inactivity, smoking, stress, poor diet. We talked about the buildup of cholesterol in the arteries. We talked about damage to the vessel walls causes platelets to stick, and then you get stuff that slams up against there and over years, right? So different things can cause damage to the walls. Smoking, high blood pressure, high sugar diet, all those type of things can cause the blood to, or the vessels to be stressed, to be damaged, and therefore we can start to get stuff stick to them, and over years and years and years and years and years, we will end up getting clogging of the arteries, and this is what we're talking about. This is clogging of the arteries. Cardiac tamponade, okay. Compression of the heart due to fluid blood in the pericardial cavity. All right, so if we remember all the way back in here, we have this cavity, right, where we have our visceral pericardium, which is right on the heart, and we have our parietal pericardium, which is in the cavity. And in between there, we have serous fluid to reduce friction, right? Well, if we have an infection of the heart, or we have, for whatever reason, and now all of a sudden fluid starts to build up in the space between the visceral and parietal pericardium, and we get more fluid in there than we should, now we have a whole bunch of fluid in a small area. We have this heart that's inside trying to beat, and now as the pressure continues to build on the outside, it makes it difficult for the heart to contract and relax. Okay? And so when it does that, that causes compression of the heart. Okay? And what we see here is this, right? So we have our pericardial sac. We have the fluid buildup in here, right? A buildup of blood or other fluid in the pericardium that puts pressure on the heart, which may prevent it from pumping effectively, right? So contracting, it probably would do okay, right? Because it's squeezing. The problem is when you go into diastole and you want to relax, if there's a bunch of pressure on the outside of the heart, that may not allow the heart to relax as well, which may not allow the ventricles to fill or the atria to fill as well, and then we start to get an issue. You see that? All right. Cardiac, or cor pulmonale, right? Pulmonary hypertension may result in pulmonary embolism associated with lung disorders such as emphysema, right? So, if we have high pressure in the lungs, may cause things to be stagnant, make things sit around more, which we end up can maybe sometimes get a blood clot. Okay? And if we get a blood clot, we don't want blood clots because we don't want them traveling. We don't want them getting lodged in the lungs. We don't want them to be lodged in the heart, in a heart vessel. We don't want them to be lodged in the brain for a stroke, right? All these type of things, right? So when we get if lungs aren't working right, and not allowing the good exchange of oxygen, we can get some clots that tend to develop and become a problem. We do not want traveling clots. So again, there's that cardiac tamponade, the buildup of fluid around the heart. Okay, then here's an example of the arteriosclerosis. Right, over years and years and years and years and years and years, we can get the buildup of this kind of stuff. You remember in the echo, the studies when we talked about the stents. We talked about how you could see one was 90% blocked and how they went in there with a stent and they opened it up. Well, this is kind of what they're looking at. It's kind of like garbage in the pipes. And so you can't just go through there and use a little roto-rooter and just grind it all up, because then you're going to have a bunch of little floaters going around and you're going to go get lodged in a vessel somewhere, and they're going to cause a stroke, or they're going to cause pulmonary embolism, or they're going to cause a heart attack, or they're going to something. Okay, so they go in there with a stent. They try to be as careful as possible. They go and they insert it, and then they expand it out and open up that area again. Okay? Okay, so I think that's good. We're going to go with that. I think that this has been a while now. Anyway, that's a good start. If you have any questions about those, make sure that you let me know. We're going to get through this probably tomorrow. I'll give a review sheet. We'll do some review this week. And what we'll do is we may Zoom tomorrow, and then we'll have a test by the end of the week, probably Friday. Okay? We'll do a test by Friday. We'll get all the other stuff. So I need all your stuff done. I need your review sheets in. I'm going to give you another review disorder sheet. I'm going to give you a review sheet. So this will be a big points week. You can get your points in, and then we'll do well on the test. All right. Well, hey, I hope you guys are doing well. I hope you guys haven't got sick or anything. I hope you're enjoying some time on your own. This is a kind of a good test for most of you, as you'll be going on to college next year in time management. Because this is kind of how it is. You don't have to go to class if you don't want to. You don't have to do things immediately. You just need to know when they're turned in, and then they get turned in. And so it's kind of your responsibility to do so. So if you're going to procrastinate, you can expect to be up all night. If you're going to get things done, whatever. So anyway, I hope you're doing well, and we will continue on tomorrow. I'll let you know by email if we're going to Zoom or what we're going to do. All right, talk to you later.